Hello everyone. Welcome to this session on genetics and adverse drug reaction. I'm Dr. Danya. This lady developed severe postpartum pain and the doctor prescribed her a medication. Everything was fine. The lady was relieved of pain. But 2 days later, she came back to the OPD and said, "The baby is not feeding properly. She appears to be lethargic most of the time." The doctor went through the history and assured her that everything is gonna be fine. She asked her to express out the milk and feed the baby. And the next day, the baby was all blue and gray, and the cops came and infanticide was charged against the mother. You know, analyzing this is not a story. This is an original article published in The Lancet in 2006. This deals with the pharmacogenetics of morphine poisoning in a breastfed neonate of a codeine-prescribed mother. It so happened that the doctor prescribed codeine and the lady was an ultra-rapid metabolizer of codeine. So, codeine, we all know, is an active drug that can be given for pain relief. And codeine was converted to another active drug, that is morphine, which caused the death of baby because since the mother was an ultra-rapid metabolizer, most of the codeine would have been converted to morphine, which was stored in the expressed out breast milk, and that caused neonatal depression. So here comes the relevance of knowing pharmacogenetic make of each and every one of us. Every one of us are different. We could be an ultra-rapid metabolizer, a rapid or normal metabolizer, intermediate metabolizer, as well as poor metabolizer, coming to each and every one of every drug we encounter in the body. And hence, we have to be cautious while prescribing these drugs to the patients we see. The genetic make of each and every person is different. There could be a single nucleotide polymorphism, that is a polymorphism which is having a frequency of more than 1% in the population, or there could be a variation in genetic expression that is less than 1%. And similarly, there could be mutations at the level of HLA, and similarly, even at the level of drug transporters and carriers. So as doctors, we need to be cautious and knowing about the possibilities a person could have when we prescribe a drug to him or her, because the genetic make of one person is definitely gonna be different from the other. It is not even identical in the identical twins. So in this session, we'll be dealing about various pharmacogenomic variations that we could encounter at the level of single nucleotide polymorphisms or the CYP enzymes or at the level of HLA. So this is the session. We started with codeine, and in this session we saw that CYP2D6 metabolizes codeine to morphine, and if a person happens to be an ultra-rapid metabolizer, there could be pain relief for sure, because morphine is also helping in pain relief, but it could lead to more of adverse events like a neonatal respiratory depression, as in the case of a mother of a newborn, or it could be causing respiratory depression and other adverse events in the patient per se. CYP2D6 is also involved in metabolism of a lot of antipsychotic drugs like haloperidol, which is a typical antipsychotic drug, and risperidone, which is an atypical antipsychotic drug. So both of these drugs are notorious for causing extrapyramidal symptoms, but risperidone, even though it is an atypical antipsychotic drug, if the patient happens to be a poor metabolizer, more amount of risperidone will be present in the body, resulting in what increase extrapyramidal symptoms. We know that clopidogrel is an integral part of the treatment of coronary vascular diseases. Along with aspirin, it has a great role in the prevention and management of myocardial infarction. So, CYP2C19 is involved in the conversion of clopidogrel, which is a product, to the active clopidogrel. If there is a mutation in the CYP2C19, and if the patient happens to be a poor metabolizer of CYP2C19, then there is more incidence of thromboembolic events. The clopidogrel is not going to serve the purpose it is given for. However, if a patient is an ultra-rapid metabolizer of CYP2C19, guess what? More of active clopidogrel will be produced in the body, and since clopidogrel is an antiplatelet agent, it can cause severe bleeding in the patients. Warfarin is very commonly used anticoagulant. Warfarin, the action of warfarin is dependent not only on the genetic make of the person. From the sun rays the patient receives to the diet he consumes, everything can affect warfarin. So we should be knowing about the genetic presence that can affect the warfarin metabolism. Patient, if has a poor metabolizer of CYP2C9, that is a CYP2C9 star 2 and star 3 variant, then there can be an increased level of warfarin in the body, leading to bleeding. Similarly, if the patient is having an alteration in the VKORC1, that is, if the VKORC gene is producing only very less amount of VKORC, that's an enzyme, vitamin K epoxide reductase, which is a target of warfarin. In such a case, the warfarin available will be inhibiting VKORC1 and again resulting in bleeding. In another case, if the VKRC1 target is altered such that warfarin cannot bind, then it can result in resistance to warfarin and again thromboembolic events can occur. So VKRC mutation can cause both sensitivity to warfarin, that is if a less amount of VKRC is produced, and if an altered VKRC is produced, it can result in resistance to warfarin. We all know that this commonly used group of antibiotics, aminoglycosides, they cause ototoxicity along with nephrotoxicity. But consider a polymorphism in the mitochondrial DNA 12S ribosome. If there is a mutation there, it could result in mitochondrial dysfunction, which could lead to damage to the hair cells, causing complete deafness. So, while prescribing aminoglycoside antibiotic to your patient, you should be cautious about complete deafness that could occur due to this group of drugs. Moving on to a few genetic mutations in the cancer chemotherapy field. So, irinotecan is converted to SN38, and SN38 is made inactive by glucuronidation by UGT1A1, and this UGT1A1 could be mutated in a 9% of the population, resulting in less production of SN38G, which is pharmacologically inactive. So what would happen? SN38 is responsible for the anti-cancer effects, but if it is not inactivated to SN38G, more amount of drug will be available in the body, resulting in neutropenia, and diarrhea. Next, about 5-fluorouracil. 5-fluorouracil is inactivated by dihydropyridine dehydrogenase, and enough amount of 5-fluorouracil escapes the DPD and it is converted to the active drug 5-UMP and 5-FDUMP. Okay, and 5-UMP and 5-DUMP are responsible for the anti-cancer action. Capecitabine and tegafover are prodrugs of 5-fluorouracil. So consider if there is a mutation in the DPYD gene or the dimeryl synthase gene, then what can happen? If there is a mutation in the DPYD gene, that can result in dihydropyridine dehydrogenase deficiency and there is less clearance of 5-fluorouracil. So more amount of 5-fluorouracil will be present to be converted to the active 5-UMP and 5-DUMP form, and this could result in more toxicity. Yet another example seen in the cancer chemotherapy field is the metabolism of the antimetabolites 6-mercaptopurine and azathioprine. 6-mercaptopurine and azathioprine is converted to the active metabolites by thiopurine methyl transferase. So if a patient is a poor metabolizer of thiopurine methyl transferase, this can result in high levels of these drugs causing toxicity. Yes, I don't know how many of you guessed this. We are seeing a picture of red man syndrome. Now, this is caused mainly because of release of histamine by certain drugs like vancomycin or ciprofloxacin or amphotericin B. If there is a mutation in the diamino oxidase gene, there's a missense polymorphism at the diamino oxidase gene at C995C, and this could affect the degradation of histamine. So diamino oxidase is involved in the degradation of histamine, and more of histamine would lead to this red man syndrome. And again, we are looking at another augmented adverse drug reaction, that is aspirin exacerbated respiratory disease or NSAID-induced respiratory reactions. We all know that the NSAIDs inhibit the cyclooxygenase pathway and hence more of the agents are converted to the lipoxygenases by the lipoxygenase pathway, and this could increase the synthesis of leukotrienes, increasing the risk of bronchial asthma. So if there is a mutation at the LOX receptor or increase in the cysteine leukotriene receptor or even a single nucleotide polymorphism or a variation in the HLA, this could alterly affect how a person responds to even a commonly used anti-inflammatory agent or an antiplatelet drug like aspirin. So this is the Samter's triad: nasal polyps, chronic rhinosinusitis, and asthma. Along with that, if we add an NSAID that can exacerbate the respirations, causing a clinical tetrad. So we have done what mutations or genetic polymorphisms at the level of enzymes which could be possibly causing so many augmented drug reactions. Here in this slide we will be dealing about a mutation or a genetic variation at the level of a carrier. SLCO1B1 is an organic anion transporter which is involved in the carrying of statin from the blood to the liver. So what happens if there is a mutation in the SLCO1B1? There will be more of statins in the blood causing increased myopathy, rhabdomyolysis. So when the patient experiences adverse events like this, what happens? The compliance to the drug is decreased, causing more of coronary vascular events. We all know that statin is very important for the management and the treatment of hyperlipidemias, dyslipidemias, and for the prevention of myocardial infarction. So, while prescribing to statin, think about the possibility in the genetic mutation of the organic anion transporter. This is very less. The mutations or the genetic variation is very less. But while prescribing, just keep in mind that this could be a possibility of decreased compliance to the drug, resulting in failure of the treatment. Now coming to the last part of this session, we have dealt with enzymes at the level of CYP or the individual enzymes. We have also seen one example of the carrier mutation. Now each one of us have these, the hetelase in our chromosome 6. So there's a class 1 consisting of HLA B and C, and HLA 2, HLA DP, DQ, and DR, and between HLA class 1, ABC, and DP, DQ, DR comes the HLA class 3, and there are many more. So in our chromosome 6, the HLAs, these can present our drugs to the natural killer cells as if it is an antigen, and this can result in so many adverse drug reactions like a drug-induced liver injury or severe cutaneous adverse drug reactions or agranulocytosis. So HLA is associated with so many adverse drug reactions. So in this table we can see so many drugs and HLA and the mutations associated with this. Let us see a few of them. For example, we know that clozapine causes agranulocytosis, that is because of the production of nitrogen ions which deplete ATP and glutathione, causing degranulation of the granulocytes, causing agranulocytosis. But there is a pure association with the DQB star 126, which can cause increased incidence of clozapine-induced agranulocytosis in such patients. Similarly, Abacavir, if there is a mutation at the B star 57.1, there can be severe Abacavir hypersensitivity and it is absolutely contraindicated. B star 15.2 association with Abacavir is associated with the DRESS, and carbamazepine star 31 is associated with Stevens-Johnson syndrome and toxic epidermal necrolysis. Now, a few headings which are important. One drug, one genotype, and several outcomes. That is, a B star 50 mutation can result in allopurinol SJSN10 as well as DRESS can occur in such patients. If one drug, several genotype, and one outcome. So as shown in the slide, we can see that this one drug nevirapine, it could have several different genotypes associated with. We can see all the HLA class 1 genes, A star 24, the most important one, C star 4, C star 8, and B star 35, all involved in nevirapine induced drug reaction, that is DRESS. And another one is several drugs, one genotype, one outcome, that is carbamazepine, phenytoin, and phenobarbital, several drugs, and one phenotype, that is B star 15.2, producing a single outcome, that is STS10, can occur in all these patients. So we all know that a lot of things or a lot of events are happening in our liver. Liver is one of the most tolerogenic organs in our body, and the incidence of adverse reaction, that is drug-induced liver injury, is actually very less coming to the comparison with the amount of work it is doing. So we need to screen about 1 lakh patients to detect drug-induced liver injury. We know that association of HLA as well as various metabolic enzymes, especially the acetylators, and there has also been predilection with gender, ethnicity, and mitochondrial variations, alteration in the drug transport and clearance, as well as detoxification process errors. So here, let me cite a few HLAs, that is HLA-DR B star 15-1, that can cause severe a drug-induced liver injury in patients consuming very commonly used antibiotic, that is amoxicillin clavulanic acid. Amoxicillin clavulanic acid is very commonly prescribed, and while prescribing this to your patient, just think about a possibility. If the patient is having a variation in the HLA-DR B star 15-1 or A star 30 or B star 18, the patient could present with drug-induced liver injury. Similarly, flucloxacillin has been associated with HLA-DR B star 15-1. We all know that INH is metabolized by acetylation, and if the patient is a fast acetylator, the patient could develop hepatotoxicity. But there are a lot of recent studies which shows that even slow acetylators could develop hepatotoxicity. We all know that G6PD is a very commonly occurring X-linked mutation, and you could be a normal person that's a wild variant, a carrier, or affected. And we have to be cautious while prescribing drugs, anti-malarials like quinine or chloroquine, or the anti-leprotic dapsone, or even any sulfonamides, or even some fluoroquinolones. This could possibly cause hemolysis and hemoglobinuria, and the patient can present with jaundice. Aplastic anemia could be autosomally recessive, that is linked to the BRCA2 or FANCA or FANCC, and it could be even autosomal dominant or X-linked. And we have to be cautious while prescribing chemotherapeutic agents as well as radiotherapy to these patients, because these patients can present with aplastic anemia if the patient is having an autosomal recessive or autosomal dominant or X-linked gene. Now coming to the heart. When hydroxychloroquine was repurposed for the treatment of COVID-19 these days, one of the cautious signals that was generated was that of long QT syndrome, and especially when it was prescribed along with azithromycin, we were warned that long QT syndrome could occur. So not only hydroxychloroquine or azithromycin combination could produce long QT syndrome, Torsor de bonds and prolonged QT interval has been associated with so many of the cardiac antiarrhythmics as well, class 1A and class 3, and certain agents like cisapride or mosapride or antidepressants. All these patients could develop long QT syndrome. So if there is a genetic mutation, for example, a loss of function of the KCNQ1 gene could result in long QT1. And if there is a loss of function of the KCNH2 gene, it could result in long QT2, and a gain of SCN5A could result in long QT3. So just be cautious while prescribing these drugs to the patient. There is a possibility of mutation at several levels, and a loss of function of the SCN5A could result in a Brugada syndrome, idiopathic ventricular fibrillation, progressive cardiac conduction disease, and congenital sick sinus syndrome. And not last, even though it has been kept to the last, this is the most important and the most common thing we see. This is the most notorious, the least accepted by the patient, that is severe cutaneous adverse drug reaction. It has been associated not only with the HLA. As I already told, the HLA can present our drug as an antigen to the natural killer cell, causing severe cutaneous adverse drug reactions or drug-induced liver injury, or it could be a granulocytosis and Stevens-Johnson syndrome and toxic epidermal necrolysis, or an SJ10 overlap, is one of the notorious and most dreaded adverse drug reaction um, associated with the use of drugs and proper association with HLA B star 15 to B star 58 and B star 57, especially as I already mentioned, abacavir. Abacavir is contraindicated if a patient is having an HLA B star 57 mutation, or similarly if a patient is prescribed amoxicillin and clavulanic acid or flucloxacillin. This patient could not only present with a drug-induced liver injury, there are possibilities of SGS and 10, and this SGS10 is not only related to the HLA, but if the patient is a poor metabolizer like the star 2 and star 3 variants of CYP2C9, then what happens? The drug level will be more than expected, causing again severe adverse drug reactions. So as doctors, we should be cautious of these possibilities. That is a possibility of genetic underlying cause that could have resulted in the adverse drug reaction. So what is the input? So at all the levels, we should avoid misdiagnosis. We should not shun the fact that it could be a genetic mutation. We should always avoid misfocus and would properly put on the effort to investigate more on the matter and find out if there is an underlying genetic mutation or any underlying genetic cause, and possibly seal any missing information. This is very important for signal detection and risk calculation and correct assessment of the event. Now, what is the throughput? There's a lot of database available worldwide, like the Registrar, the Berlin Case Control Surveillance Study Group, the International CA Consortium, HLA Adverse Drug Reaction Database, as well as the LiverTox database. So they increase the collection of the cases and the quality. They have standardized collection forms, and they analyze the genetic material and even do re-identification of the patient. So what is the output? So when you come across a patient, try to put it as a case report or combine several polymorphisms and form a complex genotype, several reactions into a single syndrome, or several drug into a single class, several drugs into a single drug class, so that we can properly generate a signal. Now, what is this important for? This is important for statistical significance, so that we can do further calculations. Technical signification for validating the test, whether it is having a positive predictive value or a negative predictive value, and clinical significance, that is the patient per se gets the benefit by identifying whether this test is a positive, having a positive predictive value, and identify the personal risk of the patient, and of course economic significance, because we can ascertain the number needed to screen. This is most important at the level of implementation, because we are all reluctant to go for pharmacogenetic testing, especially in India, because of the monetary implication behind that. So this is very important, the number needed to screen. So if possible, try to draw about similar case reports which are having common implications and form a single class or a single, rather than sticking around to a lot of different signals. Try to bring about the signals together so that the output could be beneficial to the society. So what is the take-home message? As I've already told, no two persons are identical, not even the identical twins. Each one of our patients could have a different genetic make. So while prescribing the drug, think about the possibility that the outcome of the drug could be variable, not only because of the lack of compliance or the difference in the disease progression. It could be because of an underlying genetic make. This could be because of a variation in the genetic make. Any report of adverse drug reaction should act as a red flag for the detection of or for the screening of a genetic underlying cause. So, hoping that personalized medicine would really come in the future. This is Tanya signing off, and thank you. Thank you.